So I'd like to introduce our current spine fellow, Luis Daniel Diaz-Aguilar. He's an R3 at UCSD, and he's doing an enfolded fellowship this year. He's absolutely wonderful, and he's going to talk about his great experience with cervical spine trauma while on our service. Danny got his undergraduate training at Johns Hopkins in neurosciences. Then he went on to UCLA for his MD, and now he is currently with us. So take it away, Daniel.
All right. Well, thank you all very much for this opportunity to be able to share my experience and what I've learned so far. It's just so wonderful as a San Diego native to have discovered such a wonderful group right in my own backyard. And so I'm very excited for today's topic. So as described here, we'll be discussing the subaxial cervical spine trauma and its associated indications. In the standard fashion for most trauma workups, the initial protocol should be evaluation of the patient, resuscitation by the appropriate advanced trauma life support protocols, avoidance of hypotension, and evaluation by either the Nexus or the Canadian C-spine rules. The Canadian C-spine rules listed here, which shows a flow diagram of high and low risk factors to determine whether the C-spine should be cleared, and the role for additional imaging, which will generally consist of an initial AP and lateral x-rays followed by a non-contrast head CT with a consideration of an MRI and CTA versus MRA following further evaluation and resuscitation. Following the acquisition of the appropriate imaging and evaluation of the patient's neurologic status, those with evidence of subaxial injury, the decision then focuses on the role of conservative versus surgical intervention. Now, the subaxial cervical spine injury classification is a powerful tool. It incorporates fracture morphology, the integrity of the discoligamentous complex, and of course the patient's neurologic status to assist providers on clinical decision-making. The point system very closely mirrors the previously discussed TLIX score, with a score of less than 3 being non-surgical, 4 indeterminate, and greater than 5 indicating the role for surgical intervention. Now, there are a number of fracture subtypes that are well described within the cervical spine. Today, we'll, of course, focus on those between C3 and T7. Working through the subcategories of the SLEX score, we are able to begin with those non-surgical permutations. Cases with, say, isolated TPs, spinous processes, or laminar fractures without neurologic deficits or evidence of discoligamentous injury are clearly non-operative. Fractures such as burst fractures or compression fractures with lower scored neurologic deficits will frequently necessitate an MRI to ensure that there is no disruption of the DLC and may still be treated non-operatively with a score of 3. Treatment non-surgically generally consists of a cervical collar for immobilization with frequent radiographs performed to monitor reduction and alignment, usually with dynamic films near the end of the 12-week period to ensure no further changes. And of note, all general available cervical collars provide restricted movements within all planes of movement, with this study suggesting that the Aspen collar actually demonstrates the greatest amount of restriction, especially when compared to the Vista as well as the Miami J collar. Halo orthosis may also be employed as a more definitive external fixation by fixing the skull to the torso. It certainly provides the most rigid form of cervical spine external mobilization. However, it is not a benign procedure, and contraindications and considerations for patient selection should be evaluated prior to the placement. Factors including cranial fractures, sepsis, obesity, cachexia, altered mental status, dysphagia, dementia, even advanced age have all been associated with a higher than potentially tolerable morbidity and mortality. Before we move on too much farther, I wanted to highlight the value of this spine trauma study group algorithm, which has provided a systematic review of the literature and workflow for the surgical approach based off of the SLEX categorization, and is a helpful tool for the provider in determining what is the appropriate approach and type of surgery for a given fracture morphology as well as injury status. So notable examples of commonly seen indeterminate injuries include a burst fracture with disruption of the discal ligamentous complex without any neurologic impairment. Conversely, on the opposite end of the spectrum, a patient with no fracture morphology or disruption to the discal ligamentous complex, but with an incomplete deficit or with evidence of continued cord compression secondary to spondylolisthesis would be considered indeterminate. Such a patient could be considered to have central cord with the setting of cervical spondylosis. And the treatment for this is fairly controversial when the patient presents within a trauma setting and a new neurologic deficit. Class 4 evidence suggests that surgical decompression of these patients who demonstrate a progressive neurologic defect or stable incomplete defect with evidence of canal compromise secondary to the spondylitis, potentially in the setting of congenital canal stenosis, have actually an improved neurologic outcome, as can be seen here by the initial Frankel score, the non-operative groups in the dark, with the remaining 3 stratified based off surgical time, demonstrating a significantly improved Frankel score 3 months out from surgery. Interestingly, the 3 stratified groups, surgery on within 24 hours, after 24 hours, and as returned to the hospital, did not demonstrate any significant difference. However, this is a retrospective study, and further prospective studies with larger groups may further serve to elucidate this. Moving on to the surgical treatment cohorts. These consist generally of higher grade fractures, including those of rotation and translation, the majority of which will come paired with disruption inherently of the disco-ligamentous complex, or looking at burst fractures without DLC disruption, but continued evidence of neurodeficit. Here we can see such an example of a burst fracture without DLC disruption. However, given this retropulsed fragment of the vertebral body, it is very likely that this patient does have a type of cord injury and does have the compression modifier, leading to an SLIC score of between 4 and 6, suggesting it is operative. As such, per the workflow, we would then see that the suggested procedure and approach would be an anterior cervical vertebrectomy cage or strut graft with an anterior cervical plate. Now, in regards to the decision between an anterior versus posterior within burst fractures, there are no level 1 or 2 studies, but a group of level 3 studies do suggest that anterior decompression is favored when surgery is indicated, primarily because of the ease of access to the patient source of ventral decompression, the decompression of which could be done, of course, under direct visualization. There's always a consideration of performing a combined procedure, specifically when the patient has a loss of lordosis, evidence of congenital canal stenosis, where direct decompression might be even more valuable than the potential indirect, and then patients with ankylosing spondylitis or DISH, which we'll discuss a little further later on. Similarly, patients with hyperextension fractures, typically with an avulsion or teardrop fracture, have at default a presumably surgical morphology, given the 3 points granted for the morphology and the very high likelihood of DLC disruption. Again, an anterior approach would be recommended, with the potential of adding on a posterior for stabilization in certain patient cohorts. Now, a notable property of distraction injuries of the cervical spine include the presence of facet injuries. These can be unilateral, bilateral, range from simple disruption of the joint capsule to an incomplete dislocation perched, or a fully complete dislocation locked. The suggested cervical approach within this permutation of the disease is once again anterior, given the presence of disc herniation into the spinal canal. However, now, if we are able to appreciate a facet subluxation without evidence of disc herniation approaching, then we now have the option to consider a posterior reduction or potentially the anterior itself given the lack of need for ventral decompression and the possibility of the patient developing segmental kyphosis or posterior ligament infolding. Now, early closed reduction for the restoration of anatomic alignments in the cervical spine in awake patients is generally recommended. It is a well-established and useful technique that can be done in the ED, ICU, or within the OR itself prior to intervention in patients with an appropriate level of consciousness and generally under direct fluoroscopy. Typically, once a Gardner Wells or a halo is placed, initial 5 kilograms is placed and then an additional 2 kilograms per segment added on over the prolonged period of time with frequent neurologic monitoring and fluoroscopy to ensure that the patient does not develop any new neurologic deficit or changes, at which point the traction may have to be halted. Moving on to rotational and translational injuries. These are almost always surgical, with subcategories initially focusing on the integrity or the presence of fractures of the vertebral body versus none at all with a complete displacement or translation. As the example seen on the left, looking at a permutation of a translation or distraction injury with compression on the M plate leading to a fracture, it may be tempting to simply approach such a procedure anteriorly following the reduction with an anterior graft. However, some class 4 data does suggest that up to 2/3 of patients with evidence of end plate compression and a translational injury, when fused only by anterior approach, will develop early mechanical failure. Thus, the recommendation is primarily a posterior approach with the addition of an anterior earlier on for decompression of any ventral disc or other source of compression. Similarly, this will occur, or this decision leads to an anterior and posterior decompression for vertebral burst fractures, which are associated with facet subluxation or rotational injury, as you will use the anterior approach to assist with the decompression of the retropulse vertebral body fragment, and then finally proceed with a posterior approach to ensure stabilization and complete reduction. The final subcategory of this decision matrix consists of patients with no anterior vertebral body disruption, but evidence of facet fracture dislocation and subluxation. To illustrate this, I hope to quickly go through one case, which I believe will highlight a number of concepts described earlier and within this category. So very briefly, 53 male, Peds versus auto, physical examination, oriented ×3, completely flaccid in the right upper extremity, 4+ in the left bicep, 3 in the wrist, triceps, nothing within hand grips, nothing within bilateral lower extremities, sensation intact throughout, with perianal sensation, no volition. We can identify that this patient has a completely intact sensorium, a right motor level at C4, left motor at C5, the lesion at C4, and Asia B. So a C4 Asia B incomplete spinal cord injury. Here, by evaluating the sagittal CT, we can determine this is a stage 3 bilateral facet dislocation with approximately 50% translation of the vertebral body. So C5-6 bilateral lock facets, stage 3. We know that this is a surgical morphology as well as DLC with neuro, providing a complete score of greater than 4. So our assessment and plan, our next steps. Before I jump into that, I wanted to quickly re-highlight the value of rapid and emergent surgical intervention. It has been well established that in the case of spinal cord injury, time to the OR, less than 24 hours, or in some cases, less than 48 hours, provides value to the patient and better outcomes. This recently published meta-analysis of various spinal cord injury trials released in The Lancet in 2021 confirms this further with increasingly shorter time to OR leading to a better surgical outcome. Ideally, less than 24 hours will lead to improved motor, light touch, pinprick, as well as final Asia score. However, the authors note that the apparent critical period may extend up to the 36-hour time mark, at which point emergent surgery should still be considered if the patient presents at such a time. Moving back to the case discussion, the plan initially would be to attempt a closed reduction, MRI to assess for disc herniation, and then emergent anterior versus posterior surgery for instrumented decompression and fusion. As discussed earlier, placement of Gardner-Wells tongs, initially with 5 kilograms and 2 kilograms for each segment. Fortunately, this patient is awake, lucid enough with an intact sensorium, able to describe their neurologic status. And the initial plan would be to perform traction with a small amount of flexion component in attempts to relieve this locked facet. As such, we can see here the placement of halo and then a high pulley used for flexion vector with the addition of weight incrementally, 20 pounds, 30, 40, 50, 60, up to 70 pounds. And although there have been reports of weights up to 140 pounds being used safely and successfully, at this point, the patient developed changes, paresthesias to their upper extremities. And so the traction was aborted and the patient was sent for MRI. Here we can see the failure of the reduction once the weights have been relieved. The reason for the MRI, as previously discussed, and simply want to include this diagram, demonstrates the need to understand whether there is a disc fragment which will continue to be extruded and may be left following the operative procedure if the information was not available and decompression was not achieved. And so looking at the axial and the sagittal CTs, moving on to the MRIs, we are able to appreciate a posterior disc fragment which would need to be decompressed ventrally. And so at this point within our algorithm, we can see that there is disc within the canal. Our initial approach will be an anterior cervical discectomy with open reduction, given our closed reduction was not successful, with the consideration and possibility of moving to a combined anterior and posterior approach should we not be able to successfully reduce this fracture. As described earlier, we have this posterior disc fragment, therefore a solo posterior cervical fusion is not the appropriate procedure for this patient. Here's a few diagrams quickly describing the ventral distraction techniques. For example, use of an interspace spreader or convergent distractor pins placed within this trajectory vector in order to create kyphosis, which is slightly different or the opposite of the placement of these distractor pins when performing an ACDF, where they will instead be divergent, creating posterior lordosis and spreading open the disc space, versus here with the creation of kyphosis posteriorly. And of course, there's manual reduction and then the use of curettes or various instruments to achieve leverage and manual reduction. Here, very quickly, we can see the use of a laminar spreader, which incrementally is able to lead to complete reduction of the facets, the placement of an inner body and anterior plate. Through this success, the need for a posterior approach was deemed to be not necessary. And very quickly, as a follow-up, the patient did extraordinarily well, returning to clinic 3 weeks later, completely intact in the bilateral lower extremities, 2 out of 5 in the right upper, which was previously entirely flaccid, and essentially 4+ in the left upper extremity. Additional considerations for patients which should not be missed, especially those with dish and ankylosing spondylitis, both of which are progressive fusions occurring within the cervical spine or throughout the spine itself. But with a focus on the cervical spine, we see that they over time begin to resemble long bones, leading to increased lever arms superiorly and inferiorly to any potential fractures. And as a result of stress shielding, the overall bone mineral density of the spinal column is lower than a control population, as could be explained via Wolff's law. Surgical fixation is generally the treatment of choice in indeterminate or otherwise indeterminate injury morphologies, as described earlier. The larger lever arms and the poor bone mineral density leads to a greater rate of instrument failure. And by using a posterior approach, long bridging constructs could be created to improve overall stabilization and are generally necessary in patients who may otherwise tolerate a solo anterior approach. Additionally, a high index of suspicion should be maintained in patients who present to the trauma bay with AS or DISH, who solely have neck pain. These patients can be quite complex as they generally have neck pain at baseline and may have hidden fracture morphologies, which may be disastrous if not fully recognized. They generally can hinge on the posterior fulcrum, which may reduce easily while laying supine. And those patients with fixed deformities may also develop an iatrogenic injury when placed in cervical, when the cervical collar is being protected, if the injury is not initially identified or the fixed final deformity is not appreciated. Now the wall of text regarding essentially all of the indications and conclusions that were described earlier. For the sake of time, I'm not going to read off every single one, but it essentially endorses the use of the SLIX classification as a use for the guidance of subaxial cervical spine injury, the benefit of MRI, and then the stratification of the SLIX score as described earlier, with the role for surgery being considered for those earlier on, for those greater than 4 or when determined to be candidates at 4. The role for posterior surgeries for those who require larger constructs and with complex injuries. And then the suggestion of consideration for posterior surgeries in those with osteoporosis or ankylosing spondylitis. Similarly, this endorses the use of traction, especially within the acute period prior to the OR, within the emergency in the neuro-intact patient. This is a simple snapshot of the references and the sources that I've used. There were numerous papers. The reference sheet was extraordinarily long. So if anyone is interested in any particular paper, I'm more than happy to pull up the data and forward it on offline. Thank you very much.
Thank you, Danny. That was fantastic review of the CLIC system.
Awesome, Danny.
Very
Thanks,
nice.
man. Hey, just out of curiosity, what are kind of the protocols at UCSD given the different scenarios with presence of spinal cord injury and the use of steroids?
Yeah, so steroids is a topic I've very much considered including here, but I feel that that could be used in its entire 30 minutes of its own. It's changed since I've been there, and it also depends on attending preference. Generally, we've moved away from the use of steroids, given the questionable methods seen in some of the papers describing its use, but there are still some attendings who will suggest for it, and a lot of it can be driven by that protocol as well.
Gotcha. So no standardized approach at this point.
Not that I've seen, especially. It really is more attending driven.
And Greg, what about its scripts? What do you guys use for protocol?
In general, the protocols in place to not use it, and if it is to be used, it has to be spine surgeon initiated. The only time that frame that it would be a reasonable consideration, I believe, is in that that patient that arrives 2 hours from their injury, you get them on the protocol and you get them to the operating room in a very short period of time. There may be some benefit in that very early group rather than in the later group. That's probably the more controversial group, but I think some consideration should be to keep that on the table for that. But in general, at Memorial, I should say, I don't know what happens down at Mercy, but at Memorial, the physician has to initiate the protocol if they want it, but the trauma surgeons will not.
Wonderful. Well, thank you all very much for your time.
Thanks a bunch, Daniel.
Awesome. Thanks, Danny. Appreciate it.